Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Kevin Irwin on critical updates to overdose prevention. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold the questions until that time, or you can place them in the chat feature in Zoom. Slides and materials from today's webinar will be sent out in a follow-up email. And now I'd like to give a quick introduction to our speaker today. Kevin Irwin brings 30 years experience working at the intersection of public health, practice, policy, and research. His mission to improve individual and community health equity and well-being for marginalized populations has always been driven by his own gratitude as a person in recovery. And with that, I will hand it off to Kevin for our presentation. Thank you all for being here today.
Thank you, Bethany. Really appreciate it. I get the feeling you've read that intro before. So, hey, everybody. I won't reintroduce myself. Just to say I am Kevin, and I'm here on behalf of RHI, which is Reduce Harm Incorporated. There's a link there to our website if you want to get to know us a little more. I'm also going to let you know that I'm going to go off camera while I go through our slides, and then I'll come back on camera. But RHI is a small group of just a few folks, very much like me, been doing this a really long time. As harm reduction has started to come to fruition over the last few years and get the kind of recognition and support it should have, we were keen to be there and offer our own kind of technical assistance, training, support, whatever it might be, to agencies, organizations, individuals around the country. So just in a couple of years, we've been active in 16 states, Puerto Rico. Just signed a contract with the Veterans Administration to support harm reduction in their clinical settings, and so making a lot of progress, and also want to acknowledge the Maine Office of Behavioral Health is funding us here today. I do have the same disclaimers that Bethany already shared. Whatever I say is really coming from me. It's not the opinion of anybody else. And I want to make that clear, but I'm really grateful to the Collaborative for making this all happen. So here I go off camera for a moment, for a little while. Our objectives today, we'll take a look at, and I want to say I don't assume that everybody has been to 37 overdose trainings. The possibility that many of you have is very, very high. And I know that we're going to be reviewing some information that's not necessarily new, but we do always want to acknowledge and include anybody who hasn't had a lot of exposure to overdose prevention. And so we will review some pretty basic stuff, which is in part why I am going to be talking fast and moving quickly. These are also relatively dense slides. There's a lot of them. That's on purpose because we share the slides afterwards so that everybody can take a closer look. As well as in the notes section, I have many, many citations and references to information that I share. So whatever I share, again, is not necessarily just my opinion. It's backed by the research and science in the field. So we'll review the basic epidemiology of overdose, incidence, mortality, what we know works already. We're going to talk especially about what we're seeing in the drug supply. Many of you are very aware of how that's been changing and shifting and increasing our uncertainty about what to do and how to do it. And we'll discuss a range of kind of factors that shape how we historically have recognized and respond to overdose and how we have to kind of alter our practices a little bit going forward. Um, so the usual, there's many different depictions of what the overdose, epidemic has looked like. This is kind of a typical one, beginning with wave one, lots and lots of painkillers in spaces where they weren't before, and then the response to that was constriction of access to all those painkillers, which created wave two of overdose as people who were accessing those then turned to the illicit market, which was still dominated by heroin at the time, but still resulted in an increase in overdose incidence and mortality. Then, we hit wave three, where synthetics really started to hit the market. Um, and in particular fentanyl, of course. And that's what really blew us up in terms of terrible outcomes. And then, likewise, now most of us would say there's really a fourth wave, right? There's tons and tons of new stuff in the market, lots and lots of co-occurrence with all different kinds of stimulants, especially and a bunch of other stuff that we're finding and having to respond to. And that's going to be primarily what we're going to talk about today. Certainly, you've seen many of these charts. It was really synthetic overdoses, right, that accounted for a 97-fold increase is one heck of, in epidemiological terms, that's way off the charts. But again, you can see in this depiction, psychostimulants, cocaine, and others kind of in context of they were absolutely increased um, in their finding them in the illicit market, but you can get a sense of scale there as well. But then, recently we've also heard about encouraging decreases in what had been really unrelenting increase in overdose deaths. Um, these data come from the UNC Opioid Data Lab, run by Dr. Nab Dasgupta, who I had the pleasure of working with way back in the day, 25 years ago. When we were both working in public health at Yale. NAB has really put together a wonderful institute at UNC that uses all different kinds of methods to track what's in the drug supply, the illicit drug supply, all around the country. And also tracking that along with overdose mortality and getting into the weeds about those data, what they do or don't tell us. And essentially what they found was, it didn't just drop off in the last year. Those declines started earlier and it was more gradual in 22 and 23. You can see a bunch of different states here, many of which started declining in 2022. Some took a little bit longer. And part of those data include Maine, of course, which started declining in 2023. So I would encourage everybody to take a look at the Opioid Data Lab website. And there's just an incredible wealth of information that's really informative for us there. And I will say one of the really important projects we worked on back in the day, again, almost 25 years ago, was in Maine, where we were trying to understand the impact of those pharmaceuticals. In particular, OxyContin had blown up, and trying to understand what was really happening on the street relative to OxyContin and risk among various populations. We were working in Cumberland County and Washington County. I could talk about that for another 3 hours, but I don't have time. But yeah, I would encourage everybody to check out Nab. He's just a terrific scientist and a wonderful guy. A reminder about these deaths, right, is even though we're seeing a decline, it's not for everybody, right? It's not, it's certainly among white people, but we're not seeing the same kind of decline in the Black population, Native Hawaiian, other Pacific Islanders, et cetera. So important to keep that in mind that what we're doing is effective. It's multi-pronged. It's not one thing that's having an impact. Um, but that constellation of different things that are being effective are not being effective for as effective for all populations. And again, looking at data, digging into data. If you're into data, you may already be very familiar with this website. Maine has good drug data as well. We just take a look back here at 2024, and you can see fentanyl certainly still overwhelming in its presence, along with, as we know, there's almost always many different drugs on board when somebody does overdose. But we also have seen in Maine an increase in xylazine, which you see at the back, at the bottom. And that increase in sedatives in the drug supply is really our primary focus today and the implications of that increase. So, since we're going to be talking about drugs, if you have ever seen me talk or heard me talk about this stuff before, whenever I'm talking about drugs, I always put it into context. In the framework that I've always used my entire career, that drug is absolutely imperative to understand. It is important, but focusing solely on the drug is limiting and doesn't really give us the full picture that we need to comprehend in order to respond to effectively reducing incidence and mortality of overdose and other negative consequences. So I always introduce and talk about the framework of drug set and setting, which has been very popular in harm reduction circles for a very long time. It comes from a researcher at Yale who was a doctor, Dr. Norman Zinberg, many, many years ago in the 90s, who was trying to understand actually not why so many people were getting infected or dying, but he was trying to understand why so many of his patients who used drugs didn't have necessarily negative consequences. So in his research to understand what are the protective factors as much as the risk factors, he developed this framework. The drug set and setting framework does acknowledge, of course, the drug is super important, what it is, what's its potency, and certainly today we can see potency really matters with drugs like fentanyl. What else is in there? Is it contaminated? Are there combinations? Are people using drugs in combination purposely, or they don't know it's there? Stuff that drugs on the street are cut with. All of those things are really important to understand. And then how we administer drugs, right? It makes a big difference in the consequences. Whether we smoke, swallow, inject, snort, et cetera, et cetera. Um, every piece of that makes an important difference in potential outcomes. So yes, the drug itself is super important, but so is the person. The set is the mindset. It's what a person brings to their experience. We know especially that expectations matter a lot, your motivation for using drugs, and what you expect to happen, your mental emotional state, cultural identity, physiological considerations. For example, folks with sleep apnea, asthma, COPD, all of those put you at much higher risk for overdose, especially because we're trying to address respiratory problems. Folks with heart disease, liver disease at higher risk for negative outcomes. Stigma and discrimination is just absolutely huge. The experience of discrimination and how that influences people's behaviors consciously or subconsciously is really important, especially in terms of their ability to access material, information, and support. Um, and then just straight up knowledge, right? Knowing about what drugs are, what the effect is for me, um, and how I can keep myself safer. Knowledge is super important. That's something we can always share with folks, and we should always share with folks, as well as learn from the folks that we serve. And I do want to acknowledge that knowledge alone is absolutely not sufficient, right? Um, I can tell you that, several of my very good friends who were literally the most knowledgeable people about these issues in the country and in the world are no longer with us and have in fact passed from unintentional overdose. So knowledge alone doesn't cut it. The setting in confluence with the drug and the set makes a huge difference, right? The risk environment, which is a wonderful concept that we can deploy. We know how much isolation matters, how much a lack of connections matter. Lots of different situational factors, exposure to, negative legal consequences versus, using drugs in the alleyway versus using them in our living room in the suburbs makes a huge difference. Who we use with. Um, and what are the dynamics of those relationships? What are the social and cultural attitudes towards people who use drugs in any particular setting? And there's huge variation in that area. But for overdose, we know that, the huge primary issue in terms of setting that increases risk is using alone, because if you're alone, there's nobody there to respond, right? And there are helpful adaptations. I'm sure many of you are familiar with spotting. There are websites, there are a number of different resources available where folks can call somebody if they're still alone, there's nobody there. They can establish a live connection with somebody on a phone while they're using, and that person can kind of monitor that they're still there and still responsive. So that helps, but anything we can do to help people not use alone is just critical. We also certainly are very familiar with using after periods of abstinence and where our tolerance has diminished considerably. Going back to the same dose that we left off with is super, super risky. Um, After periods, for example, of abstinence-based treatment, after periods of incarceration, where there may or may not be drugs available. Um, all of those things very, very important, and none of those change over time. In fact, some of those may escalate in terms of getting worse, through federal cuts to certain programs, through enhanced criminalization of drugs and drug use that have demonstrated over many, many years to be ineffective, but and actually increase that kind of situational risk scenario. And then, are you in a setting where folks are practicing harm reduction, providing materials, information, and support? Lots of folks are not lucky to be in that situation. And then naloxone availability itself, still not a given by any means. Whole lot better than it used to be. But out in rural areas and there's lots of situations in which naloxone is just not readily available still today. And we all know that for folks who want treatment, uh, having access to that treatment with the lowest barriers possible to be able to access it quickly is really critical. And if we're able to do that, there's certainly very strong correlation with enhanced treatment, accessibility, um, and lower overall population rates of overdose incidence and mortality. So, just the like quick review, this has always been helpful for me just to reflect on any given incident or story or experience that I've seen or been involved with over the years. Critically reviewing that in my own brain in this framework and trying to understand how the drug and the setting interacted has been super helpful in my own adaptation of how I think about my work going forward. Okay, back to the drugs. Fentanyl came in around 2014, blew up. Things were terrible. Carfentanil, a bit here and there, wasn't as prevalent as certainly it was on the news, which is often the case. But the fentanyl certainly changed everything. And I can say, for the first 20 years I did this work, the mantra was always, it's always been the same. Like we're just not doing a good enough job. That's why people are dying. But fentanyl did change everything. Um, we started to see xylazine in 2019. These drugs spread in the drug supply differently across different geographic locations. Nitazines, which didn't really blow up that much. But now, especially what we're starting to see in several places um, is medetomidine. And I'll talk a little bit more about that. Again, fentanyl synthetics. Um, uh, it was natural that these would come into the drug market. Fentanyl is easy to manufacture. It's a whole lot easier to transport without increasing your risk, especially if you're going across borders. And so, absent a really strong public health response to what was happening in overdose, it made perfect sense for fentanyl to become dominant in the drug supply. And then, of course, what happened was more and more folks, as we talked about, it's really important and helpful to know what you're taking. But almost every overdose is unintentional. But the number of unintentional overdoses that happened as associated with fentanyl with folks who may and often didn't even know fentanyl was in their drug supply escalated. Since then, we've done certainly better in terms of educating folks. Folks do learn over time. Many folks move to smoking. We do a lot of testing with fentanyl test strips and raising awareness. And just that raising of awareness alone is very, very helpful. And you can see, it really got going in Pennsylvania, Jersey, Maryland, down through there, made its way up, certainly into Maine. I don't have super recent data on xylazine occurrence in Maine, but it spread quite quickly. And we know, sorry, I have a puppy here. We know what xylazine is, right? It's not an opioid. It's a sedative. It's a muscle relaxant. We use it, on animals in surgery. And it extends the impact in periods of not only the impact that folks are looking for, but also drowsiness and sometimes disorientation when it's combined with heroin or fentanyl. And then also we're quite aware that just getting some unbelievable skin ulcers and abscesses that spread really, really quickly. And require immediate attention. But again, importantly, xylazine is it's powerful stuff, but it's not an opioid. So naloxone does not reverse its effects. So after xylazine, what we're starting to see now, as I said, medetomidine is spreading quickly. Likewise, started very much in some of those drug markets where xylazine got going. And it is inevitable. It's going to make its way up to Maine if it hasn't already. And I would point out that even what we saw in terms of the timeline of xylazine, um, bits and pieces of xylazine were in the drug supply many, many years ago. It wasn't that recent. In the early 2000s, we saw xylazine in many states, but the occurrence was relatively rare. It's more recently that it was quite intentional to be part of the drug supply. And so now we're starting to see that intentionality with the medetomidine. How are these two drugs similar or different? They're both veterinary medications. Neither of them respond to naloxone. The onset's pretty quick. The sedation is really prolonged. It's almost always found in combination with fentanyl. And sometimes in heroin as well, although heroin's been almost completely displaced in many, many drug markets around the country. Um, and it does cause withdrawal. There are some important differences. We're not seeing so far the same kind of horrific wounds, skin ulcerations and skin wounds that we see with xylazine. Hopefully that remains the case. It is unfortunately even more potent than xylazine. So the sedation that somebody experiences goes on much longer. It can go on 8, 10, 12 hours. And that's really important. And that's one of the big changes we're going to talk about today. The lowering of the heart rate can be more pronounced. And there have been anecdotal reports of hallucinations. And worse withdrawal symptoms, but I don't have scientific paper to demonstrate that yet. So that prolonged sedation, super important. Really, what happens then is overdose is and always has been about constriction of oxygen to the airway. So this has implications for reducing access to your airway for oxygen. Again, these are not responsive to naloxone, so the thing that's always worked for us no longer works. We need a better emphasis and a greater emphasis on breathing. And we have to get comfortable with this gray zone where we're keeping them alive, but they're not responsive, right? Um, so that's new, right? Usually we hit somebody with naloxone, within a few minutes, they're waking up and we're able to talk to them. This is not the case with these sedatives. Okay, so back to the basics, right? Again, to disaggregate opioids versus sedatives. Opioids in the brain, we know they're wonderful. They act on the mu receptors in the brain. They regulate lots of different things. Pain, they kill pain very, very well, but they also regulate respiration. So too much opioids kills the respiration and we can't breathe and then we die. Um, we also know that naloxone has one job, is all it does, and it does it really, really well. It attaches to that mu receptor and displaces the opioids that are on that mu receptor, reverses the effects, and by golly, people can then start to breathe again. It may only last, in some cases, 30, 60, 90 minutes, depends on a lot of different factors. But it works and has always worked really, really well. Um, so to go through the steps, right? And I think many of you have been through this many times, but there is an important shift happening now with sedatives in the supply. So we know overdose forever was not really an immediate kind of thing. It used to take 1 hour, 2 hours, 3 hours. Fentanyl changed that. What folks could go from using to full-blown overdose and arrest within minutes, which was very, very different. We know the visual signs that we look for, if muscles get slack and pupils constrict and folks nod and maybe getting scratchy and speech is getting slurred. And that's, folks are not necessarily in an overdose situation at that time. They're just super, super sedated and impacted by opioids. We don't want to leave them alone, but we're not necessarily ready for naloxone yet. Um, but then we start to see it get super limp and get really pale and clammy. Consciousness goes away. There's no response, no ability to talk. Unresponsive to outside stimulus. I'll talk about that more in a little bit. Breathing is super slow or seems to have maybe even disappeared, or it's erratic. And then we see those skin tone changes. Super important to be able to identify those. For lighter skinned people and darker skinned people, that looks different. Fingernails, lips turn blue or purpley. Those are really important indicators. And then, those kind of choking sounds, or especially the gurgling noise, lets us know that we're probably really dealing with an overdose here. And of course, the heartbeat goes way down. So before, when it came to working to try and get a response from folks, we would just to make sure they were still with us, we'd tap on their shoulder and maybe pinch their earlobe or fingertip, do a sternum rub, which you have to do really, really carefully. I've seen some awful injuries from people overly vigorously rubbing knuckles into somebody's sternum. Um, and if we're able to bring them back a little bit and be a little bit responsive, that's what we were looking for, right? And just to continue to monitor them and make sure they're awake with us. But these super potent sedatives have changed that a little bit. We're really moving from eliciting a response from people to addressing, are they breathing or not, right? Because again, ultimately, this all comes down to getting oxygen into your body. So the emergency isn't necessarily that they're not responding to you. The emergency is that they're not breathing. Really important to change that mindset. And it's also important to, not escalate all the painful stimuli and the knuckle rubs and all that kind of stuff, because all we're going to do is more harm to somebody. But rather, we want to get really good and attuned to how do we confirm that somebody's breathing. Are they getting a breath every 5 seconds is kind of the metric that we're typically looking for. And again, continue to check the lips and tips, right? Looking for those changes in color in skin. Um, what are stuff we watch for? Chest movement, look for the shoulders rising and falling. Again, looking for one every 5 seconds. Listen, can you hear folks? Can you hear folks breathe? We don't often listen really closely. Sometimes it's hard to listen if we're in a place with lots of background noise. Um, and there's other ways to check, which typically we didn't do back in the day, or we didn't have to do as much. But just take a piece of glass or mirror or some kind of an item, even a piece of plastic, and hold it in front of their mouth and nose. and see if you're able to see some condensation, and that will let you know that they are in fact still breathing. And then, as before, as soon as we determine that we're in trouble here, immediately we want to call 911. You don't have to say anybody's overdosing, just my friend's not breathing, not conscious. Give the exact location. Please don't leave. You're protected to do this. And of course, as always, don't do all the stuff that doesn't work, right? Cold showers and slapping people and all that kind of stuff. All it does is waste time and injure our friends. Okay, so time to respond. Naloxone, been around forever. Naloxone was developed in 1961. It was patented in 1966. We started using naloxone in the field as lay people, as we were called, back in the 90s. And the one in the middle, right, is intramuscular formulation of naloxone. And I want to tell you that I can't share any of the brand names of anything that we're going to talk about today. But I can share with you the formulations. The one in the middle, the intramuscular naloxone, that's what we had. I reversed my first overdose, whatever, 25 something years ago. That's all we had. That's what we used. And to save that gentleman's life cost 40 cents. Just keep that in mind. Same medication, 40 cents. We also have formulations, as you're familiar with, intranasal. Well, we started using atomizers, the one on the right, back in around 2007, 2008, just as a way to not have to have a syringe and to still be able to administer through nasal passages. Those are still around, not as many these days because there's so many other products available. And then, the intranasal sprays that folks are more familiar with these days were FDA approved in 2015. And there's a few of those formulations now. The one on this picture is a 3 mg formulation. I will say that that's a very good formulation that does the trick in most instances, even though you can still add a dose or two. There's also the 4 mg formulation. This is one that, name-wise, in terms of the company name, I think folks will be the most familiar with. But we also have these new high-dosed formulations at 8 mg, which is a huge dose. And a big 5 mg auto injector, and then a different medication called nalmefene. And nalmefene is a medication that all three of these are associated with precipitated withdrawal over a long period of time. The best I can offer you is to go right to our federal website at SAMHSA and click on this link, and you will see many more details that compare all of these different formulations with research-supported information about which ones the pros and cons of each one of those. But one of the cons certainly is that, withdrawal sucks. And it's not inevitable that folks need to be placed into really precipitated withdrawal. Precipitated withdrawal, really making somebody that sick is kind of like having the flu times 20. And it's absolutely not inevitable. We know, of course, that naloxone is completely safe. If you're not using opioids, dependent on opioids, you can take naloxone and you feel absolutely nothing. Um, but we also know that too much really is a very negative experience for folks. And now we have lots of research, and I have cited many, many references to the evidence to help you make informed decisions about these different formulations. When it comes to titrating how much naloxone we're giving somebody, the best method for titrating is using a syringe. Um, and otherwise, starting with lower doses, knowing that you can always administer additional doses going forward, right? And, as it says at the bottom, really the ideal dose is one that restores breathing without inducing withdrawal. It's not inevitable that somebody needs to go into precipitated withdrawal. Um, so more studies here that demonstrate, a difference, even moving from intramuscular to intranasal, increases the likelihood that somebody may get more than they need, but that doesn't mean don't use intranasal. Um, but the ultimately, there really is not yet any science-based evidence for super high dose or long-acting products. And uh, the stuff we've always used, to be really simple about it, is all we need. Those experiences of, 8, 10, 12 hours of withdrawal symptoms, they have consequences, right? Um, that can include, nasty side effects, vomiting, diarrhea, lots of pain, accumulation in the lungs. Some folks may, if they're going to continue to be sick for hours and hours, may end up using more opioids to try to relieve that withdrawal, which is an absolutely natural thing to do, but ultimately only places them at higher risk. And likewise, if somebody goes through that kind of experience, they're also much more likely to avoid going through that experience again, which may lead them to use alone or increase their risk in other ways. Okay. The usual, how to inject. I think we all know. Um, Intramuscular formulations, 22, 25 gauge syringe, draw up 1 cc, go into a large muscle, kind of the side of the butt, the thigh, the shoulder, just get it all in there. And again, one can titrate, and it's really, really hard, I want to acknowledge, to wait for 3 minutes. It seems like 3 hours. But it is important and really helpful if you can give it that time. Okay. Um, Intranasals, we know, just peel it out, get it ready to go, and you go in one nostril, and you have to administer the entire dose. You can't titrate this particular medication, which is why a lower dose, like a 3 milligram, is better than a higher dose. And then what we want to do is rescue breathing. Hopefully, we're willing to do rescue breathing. I think rescue breathing's making a resurgence now that we're a bit beyond COVID. That was a real difficult thing. But again, the whole idea here is getting oxygen into the folks that we're serving, right? I won't go through the rescue breathing. You put your hand on the forehead, lift up the chin, make sure the airway's clear. Breathe in, look for movement, right? Look for the chest to rise, or shoulders, especially the chest. Continue to check the airway for blockage, and continue repeating until hopefully our friend comes back to us. But again, what we're really dealing with here now is the challenge of heavy sedation and being non-responsive does not necessarily mean that folks have not started breathing again. Okay, that's the critical challenge. What is happening is folks are not responsive because they're so sedated. They are breathing, but folks are continuing to administer additional doses of naloxone, which is highly problematic. Um, Also, if one is not ready, willing, or able to do rescue breathing, there's other options for getting facilitating more oxygen into the system. On the top left, the ambu bag, probably one of the most common, certainly in the street. It's a solid option. I mean, it's not super expensive. It is one use, one and done. But it's a solid option, easy to transport. In the middle, you've got oxygen tank, which is, great, but it's super bulky, super expensive. It requires specialized training, and it's not something you can carry around with you. Um, the other option to the right, kind of more recreational oxygen can, a little bit more portable and doable. It can certainly help. But keeping in mind that both of those oxygen sources are also quite highly flammable and really do require specialized training to use those appropriately. Um, just squirting oxygen at somebody doesn't help. Um, there's other facilitative resources available. The bottom left is a pulse oximeter. If you really are into necessarily trying to monitor people's oxygen level, it's not necessarily super accurate, especially out in the field. Lots of different conditions, and folks often have, wounds or calluses or other things that inhibit accurate readings, but it's out there. And then, like nasopharyngeal, that's hard to say, airways, otherwise known as like a nose hose or nose trumpet, can certainly help clear that passageway for administration of oxygen. But again, you really need specialized training to be using these. And that training is available, I'm sure. And folks get it, and it can make a difference, but it's a significant commitment. So again, it makes naloxone appear ineffective sometimes. The naloxone still can wear off, but we really, really want to be super aware of the relationship between sedation and just overdose reversal from naloxone, and really monitor breathing. It's a big challenge. When we get folks where they're breathing, whether or not they're responsive. It's great to get people into the recovery position, especially if there's space, get them into a safe place, right? Off the sidewalk or whatever it might be. If there isn't space and they're still sitting, we want to make sure that we reposition their head and their chin, bring it up so they're not compressing their own windpipe, because they won't be conscious to be able to do that themselves. We want to make sure their limbs aren't pinned down and cutting off their circulation anywhere, because again, they won't be conscious to know that's happening. Massage their limbs if this is really a prolonged sedation, keep the blood moving. If you have to leave, if you have to go somewhere for any reason, ask somebody to hang and keep an eye and do the same. So keeping folks, when we monitor the response, folks might be coming back now. Be ready. There could be in serious withdrawal. They're going to feel just awful. Stay with them, keep them warm. still might need another dose down the road, right? That's the nature of the drug supply today. Some of this uh, between the opioids and the sedatives, be ready. And talk to folks, even if they're not responding. They might be hearing you. Talk them through the process. Tell them what's going on. Tell them what's happening. Tell them how much you care. Um, Give them space, welcome them back. This is what happened. This is where we're at. And you have to respect their wishes. Ideally, everybody would, go to the emergency department or go see their PCP. But that, often is not going to be the case. So you have to respect their wishes. And then, as always, self-care. Like this is really stressful, difficult stuff to go through um, every single time. And it's super important that we take care of ourselves and acknowledge that and get the care and support that we need. So the good old 5 steps, right? Recognize, is this an overdose? What's the role, as far as I understand, of sedatives in this overdose that I'm observing? Call 911, do the response in the way that we described, and look for ways, if not rescue breathing, to ensure that oxygen is getting back into the system. Be super aware that you're not looking for necessarily a physical or a verbal response, right? You're looking for breathing, you're looking for respiration, you're trying to uh, get folks breathing again. Know how to get people into the recovery position and to stay with them and monitor the response as you go. So stuff to remember. Um, know your drugs, know their effects. I mean, this is a crazy time when the stuff in the drug supply. I mean, we do toxicology reports on folks that have overdosed. Um, it's just incredible how many different drugs are in the drug supply. Some that are having a negative effect, some that are kind of irrelevant, but there's a ton of stuff. You'll find 6, 7, 8 different drugs in there. Naloxone still works. Please do your research. Look at the different formulations that are out there. Consider the different effects. You can consider the sources of the naloxone and what kind of company that, just as we all make informed decisions as consumers, make informed decisions when it comes time to purchase naloxone about who am I supporting with this? What kind of company are we doing business with to get the best naloxone available? Remember that sedation could indeed be secondary, and prioritize breathing first, then responsiveness. This unknowing gray zone, like, do I do another dose or not, gets bigger and bigger. It's really hard to get comfortable with it. But at least being aware that we have this additional kind of lack of acute awareness and knowledge is helpful in knowing that you're treading a space there's no one right answer machine. And commitment to a compassionate comeback really makes a huge difference for folks. I hear anecdotes all the time about folks that have been reversed um, a number of times, and the experience that they have after their overdose was reversed has a huge influence on how they approach their drug use going forward and the subsequent risk that they may experience. And just remember, there's a lot of tools out there, but the only ones that are any good are the ones you're going to use. So don't add a whole bunch of tools that are just going to cost money and you don't feel comfortable using. Okay. I always myself like to reflect on what can I do? What else can I do? What can I do to reduce the likelihood of folks using alone? What can I do to enhance safety during transitions, folks coming out of jail, folks coming out of treatment? Um, What can I do to support the building of trusting relationships to reduce stigma, discrimination, uh, getting accurate information, materials, and support to folks, getting naloxone into the hands of the people who are most likely to actually be there, right? To witness. We did research years and years and years ago that demonstrated those folks who are most likely to be there are other folks that are already in your network, already probably using drugs. Could be a family member or not, but it's absolutely critical that naloxone is in the hands of folks who are already on the scene. What can I do to remove barriers to treatment and recovery services for folks that want it, when they want it, most importantly? Getting folks connected to medical, psychosocial resources, especially when folks have had really negative experiences in those settings before, that's hard to overcome. So it's again, building new relationships, possibly with clinicians or health centers or other providers, and serving as a navigator to those services in those settings. I always use the drug set and setting framework. I've learned an awful lot from doing that and reflecting on that myself. Staying up to date on drug trends is a full-time job in and of itself, but pulling together rational responses rather than the usual, hey, we're going to outlaw everything and that'll make a difference. It never has, it never will. Let's get practical about how we can serve the folks who are at highest risk. And then ultimately, I encourage anybody that wants to do these kind of trainings in increasing awareness and support for folks. Please, by all means, do these trainings. They don't have to take an hour. They can take 15 minutes. In terms of how to reverse an overdose, it can take 5 minutes. Every time matters. Every time helps. And if anybody has any additional questions that I can't get to today, I think I used up almost all the time. More than happy to respond by email. We could set up a call as well. Happy to have a call. And we are still funded in Maine to offer technical assistance to any individual or agency, organization doing this or similar work. And we're happy to use those resources to come and support you all. So by all means, if you think there's an opportunity for us to be helpful, just let us know and we can talk about it, see what may or may not work. It could be, a half hour on a Zoom. It could be all day in your agency. It's whatever is going to be helpful to you in doing the work that we all do. And again, there's our website if you want to check out a bunch of old farts like me who are comprise reduce harm. And that is like, sorry for peppering so many slides in a short period of time, but I warned you. And we do have the slides available. So.
Yeah, thank you so much, Kevin. Like Kevin mentioned, RHI is providing technical assistance and training. So if you have a specific question or a specific training need, the link to request that is right there. But since we are at the hour, I want to thank Kevin for your wonderful presentation and thank you all for joining us today. And we hope to see you again soon.
Thanks, y'all.